But let's kind of now move into what we can offer, oncologists and say, how do we treat patients with, advanced aggressive sarcoma? Let's focus on metastatic disease. So, Shreyas, what are some of the things that you think of? What do you use? What is your first line therapy? And Damon, I'm going to want to get some insight into pediatric malignancies as well, or sarcomas as well. But why don't you start, Shreyas?
So again, succinctly summarizing what we have been talking about for some time now, that I think you look at host factors, that is the patient's age, performance status, organ function. You look at their social logistics and things like that, and you look at disease-related factors. That is this the patient who is potentially curable, or their disease is something that can be resected and rendered free of gross disease? Those are the patients that we historically have favored the doublet of doxorubicin and ifosfamide, recognizing that it is 6 months of near help, a lot of toxicities, but a higher chance of response, clearly a better progression-free survival, and the possibility of other treatment options like surgery or radiation becoming an option. Yeah. Take the example of someone who has widespread disease with 3 or 4 visceral sites of metastases. Then it gets down to the nitty-gritty details of how symptomatic are they. If they're really symptomatic and the disease is causing problems, then you need a response, and again, an aggressive regimen might make sense. But with those disease sites, if their performance status is relatively good, they're still working and need to continue to work to maintain insurance and things like that. This is where, as Marty was alluding to earlier, you find the kindler, gentler Republican regimen. I don't think we need to get political about this, right? Okay, so scratch that. But so you would try to pick the kindler, gentler treatments that allow them to maintain their normal quality of life and disease control, because we want to turn this into a marathon, not a sprint. Yep. And there are, so I think, simply stated, from my standpoint, I try to figure out whether this needs to be a marathon or a sprint. Yeah. Is there a hurry up and get to the finish line objective? Or is this just something we'll slowly cruise along and be the tortoise and not the hare, I guess, if you will. Right?
Yeah, and I think this idea of adriamycin, ifosfamide, gemcitabine, and docetaxel, we've had a lot of studies that have emerged, within the last few years. I mean, similar approaches, different approaches at your centers. What do you do?
I think identical. I really think you take everything into account, and it really does highlight that experience does make a difference. I also think it's important, you don't just have one try. And with so many different drugs, whether a single agent, whether combinations, you do have several lines of therapy. The average patient in most of our practice will see several lines of therapy. I don't really feel strongly that if your first line didn't work, your second line is necessarily not going to work. I know in some carcinomas we do feel that way, that the first line is your best option. I don't feel that way for our patients here. And so I do think to I keep saying to patients, set expectations, because I do think it's very important. We know what the response rates are to these drugs, so you need to say, will it be stable disease? Will it be a response? What do you anticipate, so they know what to anticipate when their scans come in and you're checking for disease response versus progression. But I do think there are several lines, and I think we all could have subtle differences in practice patterns. We could use differences in doses, but for the most part, I think that most of us are tending to go to the same drugs in similar orders, but there really allows for variability and a lot of options for the patient.
And maybe before we get to Damon, Marty, metastatic leiomyosarcoma.
So I think particularly for a uterine leiomyosarcoma, because the number of trials of fixed dose rate gemcitabine and docetaxel is fairly robust at this point, that I often choose that as my first line regimen. It comes with its own set of toxicities. I will have some patients tell me that it was more difficult than doxorubicin-based therapy, and then I will have others feel the other way. So you just counsel patients about what to expect in terms of toxicities. And very much like Shreyas, a patient with a large disease burden, especially if there is impending organ compromise, that you can see the ureteral obstruction coming, that's a patient for whom I think 2-drug therapy is very important, because you will, though her quality of life may diminish somewhat from the side effects of drugs, that will be offset by her not needing a ureteral stent or having a large bowel obstruction that makes it impossible to give her further treatment, for example. There are some patients for whom single drug therapy may be more appropriate, and that comes into just the experience of I don't know, seeing a lot of these diseases and figuring out which treatments are the right fit for each individual patient in some ways.
And I think this is where we all have to all channel our inner pediatric oncologist too,
Right.
because what we wind up doing is appropriately tapping into the ability to support patients through aggressive treatments if it's in their best interest. You know, a locally large Ewing sarcoma is growing rapidly, and a 65-year-old or even a 75-year-old still could be very curable in that patient, and we want to treat that patient as such. And the other patients, we can do what everybody says, use good medical common sense, work with the patient on preferences, and try to be realistic about what the drugs can do, and hope for the best. Because I think the one other thing, sarcomas tend to be disproportionate for these Lazarus effects, right? Where you go through the genome, this was in the Sunday New York Times a couple of weeks ago, where you just happen to find that one molecular target, like in the PEComas and an mTOR pathway activation, or a TRK fusion, right, TRK fusion. You give them the TRK inhibitor and the thing melts away. That's the kind of world we're in right now, where we can't say, oh, that's going to happen in 9 out of 10 sarcoma patients yet. But even if it happens in 1 out of 10, or even 1 out of 100, it's made such a huge difference. It would be just a tragedy to overlook that. And I think our pediatric colleagues have always focused on small numbers and the importance of helping small numbers.
So Damon, perfect. How do you approach pediatric sarcomas, and how is it different than what we're talking about?
Yes, so the combination of doxorubicin and ifosfamide has not shown an overall survival benefit over doxorubicin by itself, but that's with wide ranges of ages, wide ranges of aggressiveness, wide ranges of degree of metastatic burden in adult patients. And so what we've heard from everybody on the panel now is that there's something about it that seems to help some patients. And when you're backed in the corner, or when it's really aggressive, or you really need something to work, we grab both agents. And so in a patient who has 5-6 decades to live to meet the median survival for a normal person in our population, there's no reason to just try one drug. And so it's definitely standard to give doxorubicin and ifosfamide for the most common soft tissue sarcomas that we see in pediatrics, namely synovial sarcoma. Malignant peripheral nerve sheath tumor is another one of the common ones that on the spectrum of, I noticed you left it out because it is a hard one to figure out where it fits on that chemotherapy sensitive or chemotherapy resistant, but I must say, in my own personal experience, it's on the chemotherapy-resistant side of that for sure. And so I really struggle to give doxorubicin and ifosfamide. I know we shared a patient very recently who made the rounds through, maybe everyone on this panel saw her, but I think we all recommended not to do chemotherapy for a rather aggressive-looking localized tumor. That's the case for the soft tissue sarcomas. For rhabdomyosarcoma, I think of it as kind of like GIST. I would put it in its own bucket. We don't use doxorubicin and ifosfamide, although both are used in select cases along with a lot of other medications. But for the traditional patient that will come with localized disease, vincristine, actinomycin, and cyclophosphamide, a regimen worked out before I was born, is still the standard of care and has stood the test of time. Cyclophosphamide has a particularly nasty long-term side effect of infertility, especially in boys, and premature ovarian failure. And so irinotecan has been now accepted as the standard of care. So a 4-drug regimen of vincristine, actinomycin, cyclophosphamide, and irinotecan to spare gonadal toxicity is definitely the standard of care for rhabdomyosarcomas.
Yeah, so that's great.